Good afternoon, everyone. We're going to allow everybody about 2 more minutes to hop on the call. Good afternoon, everyone, and welcome to the Stroke Exchange call. My name is Michelle, and I will be your moderator for today. Feel free to ask questions throughout the presentation by typing them into the Q&A box on your right-hand side of your screen, or dialing *6 to unmute your line. If you would like to zoom into any part of the slide, use the magnifying icons on the right-hand side. The slide and a link to the recording will be provided within 1 week of this call. I will now turn it over to Allison Capetillo. Allison, the floor is yours.
Thank you, Michelle, and welcome everybody. We are so glad to have you all here on a lovely Wednesday afternoon, and I realize it's still morning for some of you out in the Mountain Time Zone, but again, we are so thankful to have you here and to take a little bit of time out of your day to join us. I just want to get started today quickly and talk about our agenda for this call. One thing I would like to point out is I added a picture over here on the right-hand side of your screen of our Southwest affiliate. I don't know that we've ever really shown you guys what all that encompasses. We use the term Southwest affiliate all the time on this call, and I don't know that we've ever really shown you who all that includes. So there you can see you've got your 6 states that are included in this affiliate. So we've got people calling in from all over those 6 states, and so you have a wealth of potential for contacts and networking that you can make on these calls. If you are interested, we can always find ways to connect you with other hospitals that are outside of your market. If you're interested in that opportunity, just please connect with one of us. You have AHA quality directors in each of these states, and so likely there is somebody close to you that can work with you. The next thing we're going to talk a little bit about is our day-to-days and why we do them. I will share with you some upcoming dates. We will talk a little bit about the data for the entire affiliate, aggregate numbers. We'll talk some about some of the measure trends that we're seeing as we look at all of these reports each quarter, where we're seeing some trends and some fallout issues. I'll do a little demo with you guys. I want to show you a drill down, and I'll actually be sending out with the recording of this the slide deck. You'll also be getting a PDF file that includes a little bit of instructions on how you can do a drill down on mild and rapidly improving strokes. And then we'll close out the call with a presentation from Laura Hartlib. She's going to be giving us some information on impact of fever and stroke. So I'm going to jump right in. Our very first slide here, I apologize. So our day-to-days. This is something that the quality team at AHA started several quarters ago. You all, if you're on this call, have probably been getting emails from us every quarter that goes through, and they're long and lengthy emails. We apologize for the length of them, but there is a lot of information that we try to cram into that one email rather than trying to overwhelm your inbox with lots of different emails. So be sure to read these. These are really important. These are how we connect with you each quarter to tell you how you're progressing toward award recognition, and thus how are you performing in the guidelines-directed therapy in your hospital. You will see in the email that there's going to be highlighted measures either in red or green. This will indicate whether you're failing or passing that measure. If it's green, of course, you're passing. If it's red, there needs to be some drilling down done on that measure. As a courtesy, we'll also include the patient fallouts for the measures that are in red, so you will always have those attached to your email. So you can just quickly go in and identify which patients you need to look at. Maybe you need to do another quick check at the abstraction to see if there was maybe a mistake done. Maybe look at their documentation to see if there's something you can go back and address with a physician, or if it's a nursing issue, anything like that. These are opportunities for you to look at your process and to determine whether or not you've got a gap in the care of the patient, or if it was just a one-off, or perhaps just an abstraction issue that can be easily fixed. Last but not least, I would like to point out that this is a static report, meaning it's a snapshot in time. So we get a raw data file each quarter from IQVIA, and they send us as of whatever date we tell them to do it. We pull that file, so it's whatever your data is at that time is what is represented in that nice report that Michelle creates for us. And Michelle, our lovely moderator today, is the one who does these beautiful reports. I'm going to flip to the next screen. If you recognize these reports, this is the one that Michelle creates for us. She's worked tirelessly on this report, and it's so lovely. I love to have these sent out to everybody because it really does give you a quick look at how you're progressing toward award recognition for each of the three components. Just to go over the components of an award measure and how you would progress toward awards to get with the guideline stroke, the first thing you must always meet are those 7 achievement measures. You've got the ones you're familiar with: Arrive by 2, Treat by 3, early antithrombotics, VTE prophylaxis, antithrombotics, anticoags for AFib and A-flutter, smoking cessation, and statin prescribed at discharge. I use this one as an example. Obviously, this hospital is doing lovely. They are meeting all 7 of those measures, so they would either progress toward silver or gold, depending on how long they've been meeting these measures. Silver, of course, is if you've been meeting the measures for 12 months consecutively, and then gold is if you've been meeting them for 24 or longer. The next set of measures would be the quality measures. This is our plus award, so that's how you would reach that silver plus or gold plus achievement level. To get this award, of course, you have to have 5 of the 8 measures that are listed here. 5 of them at 75% or higher. I apologize, I didn't clarify. In the achievement measures, you must reach 85%. There's a benchmark line put up there for you. And then in the plus measures, those quality measures, you would reach those at 75% or higher in 5 categories or more. And lastly, I would like to point out our target stroke honor roll. This is another component of our measure set. And again, you cannot reach any of the plus measures or target stroke measures without first getting the achievement measures. So even if you're on the target stroke honor roll, you have to be meeting all of the achievement measures first in order to get recognized for it. In this award set, there's really 2 categories. There are the time to thrombolytic therapy in 60 minutes, and then the time to thrombolytic therapy in 45 minutes. For that 60-minute measure, if you're meeting that at 50% or more, you would be able to be recognized for just target stroke honor roll. If you meet it at 75% or higher, you would reach target stroke honor roll elite. And then the highest recognition level in this category is the elite plus recognition, and that would mean that you've met thrombolytic therapy in 60 minutes, 75% of the time, and then in under 45 minutes, at least 50% of the time. So if you see on here, you've got little green check marks under the measures where this hospital happens to be meeting all of their award recognition criteria, and you can count them up. So they've met all of their achievement measures, they've met at least 5 of the quality measures for the plus award, and then they've met, it appears they have met all of the components for target stroke elite plus. So they have green checks in each box. That would mean that they've met the criteria for all 3, and of course would be recognized for the highest level. So if you have questions about this report, we get a lot of requests. They come through and, folks look at their email and say, oh, let me look at these. And they quickly go back in and fix their data and ask that we rerun this report for them. And as much as we would love to, we just don't have the capability at this time to do that. However, we can always run reports out of Get With the Guidelines to show you how you're progressing and if you're meeting the measures after you've made those changes to your data. So if you need to do that, please feel free to get in touch with one of us. We'd be happy to rerun those reports for you, and of course, we can send them to you in an email. All right. So I'm going to move on to some important dates coming up. We are establishing these are soft deadlines. Please don't feel like if you can't get all your data in by this deadline, this November 29th I've got here, that you're going to be penalized in any way. That's absolutely not the case. But for these quarterly data emails, we would like to be able to send you data that's updated and relevant for you and that you can take back to your stroke teams and to your hospital. So this is a soft deadline, November 29th. That will be the day that the day before we go in and pull all of quarter 3 for the next round of day-to-day emails that we send out, which will probably be coming later in the year. Next, we have the International Stroke Conference coming up in Hawaii, February 5th through the 8th. February 5th is the pre-conference symposium day, so if you are a coordinator or a nurse and you are interested in this area, it's a great pre-conference symposium. The very first day is all dedicated to nursing and to just process improvement and some really, really great sessions that are held on that day specifically for stroke nurses. March the 1st is going to be the data deadline for all 2018 data to be entered and to Get With the Guidelines. The entire month of March, your directors will be working with you to finalize any issues. So if you have fallouts that you're not quite sure of, your director can help you identify which ones those are, and we can work with you till the absolute final day, which is going to be March 31st. After that, we cannot make any changes to your data. So whatever your data is on the 31st is how it's going to be when we pull your data for the awards for 2019. So if you have any questions about these dates, please feel free to get in touch with one of us. I will have the contact information for all of the directors in the Southwest affiliate at the end of this presentation. Okay. And I apologize. I need to do that. Okay, so we're going to talk a little bit about the numbers. These are aggregate numbers for our entire affiliate. And again, those are the 6 states. So just keep in mind, this is a lot of hospitals. And I believe I might have skipped a slide. Let me go back. Here we go. I apologize. So the total number of hospitals we had with data entered for this quarter, as of quarter 3, we had 248 hospitals out of 267 with current data. Out of those hospitals, we have, the yellow bar on the far right of each category is going to be the aggregate numbers for all 3 quarters. So I'm going to be presenting off of those aggregate numbers. For the achievement measure set, which I have listed below, there were 105 hospitals meeting criteria, meaning they've met 85% or higher. We have 177 meeting the plus measure set, so that's the 75% or higher in at least 5 categories. Then we have 79 hospitals reaching Target Stroke Elite Plus at this time. We have 38 reaching Target Stroke Honor Roll Elite, and we have 34 meeting Target Stroke Honor Roll. So these are fantastic numbers. Kudos to you guys for all of your hard work, and we'll be following up with this next quarter on an update on where we are for the rest of the year. So these are the averages for achievement measures. Each category is represented here. I'm again going to use the yellow bar because that's the aggregate for the entire year so far. For Ride by 2, Treat by 3, we have an average of 74% compliance. So that's not quite meeting the 85% marker. And as you can tell, that's one of the areas that we've struggled with as an affiliate. It's been a tough one for our affiliate to meet. Early antithrombotics are at 88%. VTE prophylaxis is at 84%. Antithrombotics, 91%. Anticoagulation for AFib and A-flutter is at 80%. Smoking cessation is at 83%. And statin prescribed to discharge is at 86%. So again, these are averages for the entire affiliate. So of course, those outliers with lower compliance level is going to pull it down just a little bit. But overall, we see pretty good compliance in most of these measures and not too many issues with that. These are the averages for the plus measures. So these are the ones that are the 5 out of 8 that you need to meet in order to get recognition. Dysphagia screening, you're at 71%. Stroke education, we're at 85%, always doing well in that category. Rehab considered is also at 89%. Time to thrombolytic therapy in under 60 minutes is sitting at 65%. LDL documented is at 81%. Intensive statin therapy at 61%. Arrive by 3.5, treat by 4.5 is at 72%. And then NIH stroke scale reported at 82%. So as an affiliate, we are doing wonderful. We've definitely got some positives here in the stroke education, the rehab considered, LDL documentation, and then NIH stroke scale reported. A little bit of work to be done in some of these other categories. I would like to point out while I'm on this slide, the intensive statin therapy measure. This is a measure that everybody should be looking at. We know from what we've been told by our national science committees that they are looking at pushing this measure into the achievement category, which would mean that we would need to meet it at 85% or higher in order to reach silver or gold recognition with your annual award. This is a measure that we've all had some trouble with. It's definitely one of the tougher ones, which is why they would like to push it into those achievement categories to see that more people are being compliant with that guideline. The plan is that the statin measure will be updated once the new cholesterol guidelines are released. That should be coming soon. We hope in the next couple of months we will see that come out, and at which point we will introduce the new measure. And like any other time when we introduce a new measure, you will always have a year. You will have a year to work on it. It will not be a required measure for the first year. It'll be a trade-off. You can choose that one or the old statin measure. And then after that 1 year trial period, then it will become a permanent measure where you would have to meet it. So we're looking out probably not until 2020 that would be a requirement for sure. But right now, just to keep it in the back of your mind that that's something you should probably start working on in your hospitals. That way it's not catching you off guard when it does get moved up to a requirement. The next slide I've got here is going to be our averages for target stroke. We've got the honor roll. The first category on the left of each of these boxes is the time to IV thrombolytic therapy in 60 minutes. So we're looking at 65% for all hospitals. And then in 45 minutes or less, we're looking at 37%. However, we also broke this out into the qualifying hospitals. So these are going to be hospitals that actually are meeting the volume criteria. So all hospitals, that average can get pulled down just a little bit, but when you pull it out to the hospitals that actually have 6 or more patients getting TPA a year, the average goes up just a little bit. So you see in here we've got time to IV thrombolytic in under 60 minutes is now at 76%, and time to IV thrombolytic in under 45 minutes is at 44%. That is fantastic. So that means as an affiliate, we're just slightly under the Target Stroke Honor Roll Elite Plus measure recognition. And then last but not least, we'll break down the number of hospitals that are meeting each of these categories. In Elite Plus, we've got 79 hospitals looking to meet Elite Plus this year. Elite status, we've got 38 hospitals. Honor Roll status, we've got 34 hospitals. Just a handful that are going to probably not reach award criteria this year. And then we've got quite a few in the low volume centers, but we also understand that there are going to be a lot of hospitals that just don't get a high traffic of stroke patients and that they don't meet that volume criteria. And I've got a question coming in. How is the average higher than all 3 quarters? I'm not sure.
Hi, Alex.
That's a great question. Yes, go ahead,
yes.
Michelle.
Yeah, so it's based on numerator and denominator. And so sometimes during one quarter, we have one hospital who had 2 patients, and that drops the average to 50%. But the aggregate is based off of everyone. So when you average them all out, add the numerator and denominator up, then it changes it. So it's not a flat out 80% this quarter, 90% this quarter, 80%, and we average those out. No, it's actually based off numerator and denominator for the entire cycle.
Thanks, Michelle. That's actually great that you pointed out, because when we tabulate your data at the end of the year, it's all aggregated. It's not based off of each quarter. So if you happen to have low volume one quarter and you have a higher volume the next quarter, it wouldn't count against you. It's going to be just a compiled total for the entire year. So actually that helps a lot. Thank you so much, Michelle. Okay, so arrive by 2, treat by 3. I mentioned earlier this is an area where we've had some struggle, and my gut tells me, based off of those target stroke numbers, when you look at how well we're doing as an affiliate in our in our TPA in under 60 minutes, my gut tells me that some of the issue around this measure is not necessarily the performance that we're doing a bad job. It's just that we're just getting incorrect data abstraction. And I will tell you, I've dug into some of these with some of my hospitals, and that has proved to be true, that they've selected that IV TPA was not initiated at the hospital or that it was initiated, and then they didn't put an actual reason for the delay or a reason for not giving, even though they put in this box here that there was a documented exclusion. And so I'm going to show you all what I'm talking about. This button over here on the right that says Show All is extremely important. It looks very nonchalant. It sits over there in the corner, but it's actually really, really important. So I'm going to hop over to my PMT. Just one second. I need to remember how to share my screen here. Just a moment. And Michelle, if you'll give me a heads up whenever you see it pop up. Okay. Can you see? Okay, wonderful. I'm going to see if I can get this box out of the way. Way to minimize this. I apologize, everybody. We're working with a brand new platform, so we're all still learning. Hide video view. There we go. Okay. I want to make sure we got that on my way. So I opened up our demo site here of the PMT. I just want to show you what I'm talking about. Over here in this hospitalization tab, say you've already filled in all your information for each of the tabs, and you're getting over here to this hospitalization tab. You're going to truck along and fill out all your information. And then when you get down here to this IV thrombolytic therapy section, you're going to want to indicate, yes or no, did I not give TPA or did I? Let's say, yes, we did. Let's see. Is it going to give me there we go. You put your date and time, of course. For this example, I'm not going to put an exclusion or reason for not giving because obviously we gave it, but I would want to make sure that down here, if I put a reason for giving it in greater than 60 minutes, that I'm actually selecting a reason. So you'd want to say, yes, there was a reason. And we'll say in this example that it was, we had hypertension requiring some aggressive control, and that's what put us outside of that 60 minutes, which thus put us outside of the arrive by 2, treat by 3 measure. That's just one example or one scenario. And if you do all of this, if you indicate there was a medical reason why, that would actually exclude the patient from that population, and it wouldn't be counted against you. Now let me scroll in here and point out that if you have any hospital-related or other type reasons, these are actually, they do count against you. If you indicate that it was a delay in stroke diagnosis or some sort of in-hospital time delay, that's actually not an acceptable reason for delay of TPA. So I'm going to move back up here and say that IVB TPA was actually not initiated, and that we do have a documented exclusion for why the patient did not get TPA, but that's not enough. If you just put that they have a documented exclusion right here, and you don't put what the actual exclusion was, then we cannot count it. It cannot be removed from the bucket for that measure, therefore not counting against you. So you would want to actually click the Show All feature right here and come down here and select which criteria. And be sure that you're selecting the criteria that matches the time window. So if they arrive within 0 to 3 hours, you want to make sure you are selecting the exclusion criteria for that time window. You'll notice you have exclusion criteria for 3 to 4.5 hours further down. So for this measure, because it's the arrive by 2, treat by 3, we're going to be staying up in this area, this 0 to 3 hour treatment window. And we're going to say that this patient had active internal bleeding, and that was the reason for not giving TPA. And of course, you would want to, if you go back in and make these changes, once you've realized that you're falling out because of this, you need to make sure that you come down at the very bottom and you want to save. So you can save it and return to grid, which will take you back to your patient list, or you can save and continue on the form. Just make sure you hit the submit button. I will let you know that saving as complete or incomplete does not bar you from making any changes. So if you need to come back at a later time and make changes, you can still do that. Okay, I'm going to move back over to my other screen here. Maybe I shouldn't have done that because I believe I'm going to be doing another drill down with you guys. Okay, so my next demo I'm going to be doing really quick is actually a drill down. This screenshot over here on the right that is the Get with the Guidelines Stroke, how to identify mild and rapidly improving stroke cases. I'm going to make sure that you guys get a copy of this. this is the short and quick and easy way to identify your mild and rapidly improving cases. I will say that there's a longer way to do this, and you can get a lot more robust data. However, it does require a data download, which I think is a great tool. If you're not familiar with how to do a data download, I think that that's something we can certainly work on in future quarterly exchanges. We can show you guys how to do that. But if you're just more comfortable living in the configurable measure reports and you feel like those are pretty easy for you to run, this is a great way to get some quick data out of your tool. So I'm going to show you how to do that. Just 1 second. I'll go back to my screen. I apologize. And can you see my screen okay, Michelle?
Yes, perfect.
Okay. So now I'm going to jump out and go into my Reports tab. And I will be going over here to this Configurable Measure Reports. And I'm going to say I just want to run for the whole year. You can pick whatever time frame you'd like. And again, I'm going to be sending this out so you'll have these step-by-step instructions, so don't feel like you need to write all this down. You're going to do from this Get with the Guideline, Standard Measures drop-down menu. You're going to select, you're going to want to scroll down over to this Reasons for No IV TPA, just the plain one. Doesn't need to be hospital-related. And we're going to want to do this. This is a key right here, so make sure, change your format from bar chart to patient record. And then the next thing that's going to be super important is to add a filter. So we're going to show our filters. Scroll down here. And the reason I want to do this is I want to see where do these patients end up discharging. And we're going to select all of these. And I'm also going to add TPA initiated at this hospital, yes or no. I want to say no. And we're going to do also, I want to know where did they end up. Skilled nursing, and inpatient rehab, LTAC, and all those different care facilities. The next thing I'm going to do, scroll all the way down, and I'm going to generate that report. Now, when this first comes up, and I apologize, I'm going to move this a little bit so I can expand it. This is our data set for our demo site. It's not very robust, I promise. However, when you do this in your own hospital, you should get a few more patients populating. The first thing that's going to tell us is, did they get TPA at this hospital? It was no. So I've looked here, and I know this person didn't get TPA. And obviously, because they're in this report, it was due to they had been identified as a mild and rapidly improving stroke. I apologize, that's not accurate. I said reasons for no IV TPA. If you had your own report pulled up, you would want to show filters up here. And you could scroll over here and you would be able to see under exclusions whether or not they had a reason for no TPA being mild or rapidly improving. Again, I'll mention in our data set that we have in this demo site, it does not give us that option. It only indicates that we had one patient with IV thrombolysis or thrombectomy at an outside hospital prior to arrival. But if you did, you would see down on this list that you had several that were indicated as mild or rapidly improving. And then you could scroll over further to see where they discharged. And this is important because you can obviously identify if they came in and they had a mild and rapidly improving stroke and didn't get TPA, but then somehow or another went out to a SNF or an LTAC, that they probably didn't have a good outcome. And so you would maybe want to look back at that case and find out, well, why didn't this person get TPA? Or maybe just to circle back with the physician in the ER that saw the patient to say, hey, I just want to let you know, here's the end result of the case where this patient did not get TPA. And you can let them know that they actually ended up having an infarction at discharge. So it's just important, I think, as coordinators, we don't always tie up the loose ends, and we don't always get to circle back with our physicians that are at the front end of the care continuum, and to let them know that, you know, this is the end outcome. We want to make sure that you're aware so that in the future when you make these decisions that you are kind of considering that just because it's a mild and rapidly improving stroke, they may or may not have a great outcome. So just to put that out there, I just wanted to share that with you all. I know this is a big focus for a lot of regions right now. They're really working on these mild and rapidly improving cases. If you felt like you had a ton of cases pull up on this list and you wanted to export this, you can also export to Excel. You can slice and dice your data in Excel however you like and use it in meetings or whatever you need to do. So again, I will be sending out this quick little one-pager to all of you so you can have it to use whenever you'd like. So let me jump back. I'm going to stop sharing my screen real quick. And just to clarify, Michelle, we are seeing the slides again, correct?
Correct.
Okay. And I'm seeing a question pop over here from James. Since it's so important, can the delay and no TPA, hold on, whoops, reasons be shown automatically instead of having a show all? That's a great question, James. I'm not entirely sure why, but Larissa has also indicated that we can suggest that to quintiles. My thought is that because it's such a long form, when it expands out, that maybe it had to do with a spacing issue. I'm not sure why, but I agree. I think if it just showed automatically, that would be so much better because we have so many people that miss it, that just don't realize that it's there. So we will certainly make that suggestion to them. But for now, now that I've come to the end of my content slides, I'd actually like to pass the ball over to Ms. Laura Hartlib and her colleague Delia Russell. They are going to be giving us a quick science update that's focused around targeted temperature management and stroke. And she's got some really great slides to share with you all here in just a second. So Laura, the floor is yours.
Okay, thank you, Allison. Can you see the screen where it says impact of fever and stroke?
Yes, ma'am, we can see it.
Okay, perfect. Okay, well, thanks so much for having us on the call today. I just wanted to talk with you guys for about the next 10 minutes or so on the impact of fever and stroke and some of the impacts that this has on your patients. So as we go into this, let me go to the next slide, sorry. So before we get started, I kind of want to tell you all a story about Lehigh Valley Hospital in Pennsylvania, and they don't mind us sharing this information. So Lehigh Valley is a comprehensive stroke center in Pennsylvania, and when Joint Commission came in, they actually got cited for not having a normothermia protocol and process in place. So what they did is they implemented a protocol over the next 10 months, and I want to blow this up for you guys so that you can see here. So when they started looking at their data, and this was over, they utilized this protocol in about 2,000 patients once they implemented it. And what you can see is before they implemented the protocol, the average fever range was between 38 and 39 degrees Celsius, and the average length of stay was 5 to 20 days. And then when they implemented the protocol, post-protocol implementation, the average fever range was between 37 and 37.5 temperature, and the length of stay went down to 3 to 5 days. But more importantly, you can see on the slide that mortality went from 8% to 2%. So the reason I tell this story is I just want to talk to you about the impact that fever has on subarachnoid hemorrhage, intracerebral hemorrhage, acute ischemic stroke patients, and the evidence behind it. So because right now, if you look at the studies, in subarachnoid hemorrhage patients, 54 to 70% of them will have what we call a neurofever, where it's not responding to your traditional methods of Tylenol and ice packs and water blankets. 50% of intracerebral hemorrhage will have a neurofever, and 37% of your acute ischemic stroke will also have a neurofever. So these are just a couple of studies. One is the Neurocritical Care Society just released guidelines in October of 2018 that talks about the impact of fever. And basically any neuro patient that has a temperature of 37.5 or greater, their recommendation is the use of advanced temperature management for them. And I want to stress that we're talking about normothermia and not hypothermia for this patient population. So when you hear me say targeted temperature management, we strictly are talking about normothermia and just maintaining a normal temp in these patient population. So let's talk about a little bit about the studies. So one of the studies that was published with American Heart Stroke Journal is Dr. David Greer, and it's a really large study. He collected information of over 14,000 patients, and what he found was fever was significantly associated with worse outcomes, obviously increased length of stay and mortality. Another study that's out is by Dr. Michael Dieringer that states that patients that have 38.5 to 39 degrees in this patient population, mortality and length of stay doubles. And once their temperature increases above 39 degrees Celsius, mortality and length of stay actually triples. Also, Dr. Bajadia put out a paper that states that 1/5 to 1/3 of cases remain unexplained after a workup. So basically, after Tylenol, water blankets, they still have that neurofever. So let's talk about that a little bit. So this slide here will show you what fever, the impact that fever has on the patient and metabolic demand. So let's say that your patient comes in at 37, but then an hour later, their temperature goes up to 38 degrees Celsius. Most hospitals' first line of defense is obviously Tylenol. But if you notice over on the left-hand side, that 7%, that's the increase in metabolic demand on the patient as their temperature increases. So that left column is metabolic demand percent increase. The middle column there is obviously Celsius, and the right in Fahrenheit. So what happens after Tylenol doesn't work? What if I'm your patient and you've given me Tylenol, and an hour later nothing changes and my temperature continues to climb? Now we're up to 39 degrees Celsius. You notice metabolic demand goes up by 15%. So now the typical nursing intervention is to throw wraps, blankets, ice packs, another dose of Tylenol or ibuprofen. You can see over on the right-hand side, a lot of things are affected by temperature: heart rate, blood pressure, MAP, ICP, CPP. All of this is affected by temperature. So now you're at the point where none of the conventional methods have worked, and so the temperature continues to climb. If your patient gets above 40 degrees Celsius, look at what happens to metabolic demand. And now your patient's in a state of uncontrolled hyperthermia. And so this is where a lot of hospitals around the United States, especially comprehensive stroke centers, have implemented normothermia protocols, where at that point they will actually implement an advanced therapeutic normothermia. And that's either with a non-invasive Arctic sun or invasive catheter. Both of those are advanced therapeutic modalities that you can use for normothermia for this patient population. So this is just a sample patient case. If you can see, everything in yellow corresponds to the patient temperature. That yellow line is the patient temp. The dotted line is the target, and the blue line is the water temp. So this patient came in 39 and above, but this device controlled the patient very accurately throughout therapy. And the biggest thing is what's your hospital's practice? And my colleague Delia and I cover half of Texas, and one of the things that we've noticed is even in the leading institutions, not everybody has a formalized normothermia protocol. Everybody has the standard of care with Tylenol and water blankets, but then at that point, when we ask them, what do you do if that temperature continues to escalate? They cross their fingers, they pray, but there's just nothing else to go to at that point. So what is the best practice at your hospital? So obviously you're going to need a champion, someone who understands and believes in the importance of therapeutic normothermia for this patient population. And then the biggest thing is clearly defining what fever is in your institution. And there's a range. Some people, now that Neurocritical Care Society, and also there's another study that was published by the British Journal of Anesthesia. It's actually 9 thought leaders in the world of neuro, if you will, that published also just recently their findings. And they also stated 37.5 would be their definition of fever. However, a lot of hospitals will claim 38 degrees Celsius, 38.3. Whatever it is, it's so important to clearly define that. And so that once that threshold is met by that patient, that something is instituted, that your normothermia protocol is instituted. Because if there's not a clear definition, all of a sudden 38.5 becomes acceptable, 38.9 becomes acceptable. So it's really important to clearly define that. And then obviously implement a stepwise approach that's really easy to initiate. So you know after 1 hour, if Tylenol is not working, what's next? If your ice packs and water blankets are not working, what's next? And on the last slide, it will have our contact information. And we've got sample normothermia protocols from all over the United States at some of the leading institutions. So don't recreate the wheel. I know you've got a lot of stuff on your plate. So if there's anything that we can do to provide you some of those sample normothermia protocols, it'd be very impactful for your patients. And the last thing is that once you have your protocol in place, by regularly reviewing your patient cases and outcomes with your teams, with your physicians, your clinicians, your stroke coordinators, providing those gap analysis reports where you can look at, here's our protocol, here's our practice, where are there gaps, so that you can train to those gaps and really implement a successful, sustainable normothermia protocol and program. And so these are just, if you are in Texas, my name's Laura Hartley, my colleague Delia Russell, please copy down our email addresses. We're happy to send you some normothermia protocols and any clinical evidence that you need. And then my colleague's information is also listed there if you're in some of the other states or areas. But does anybody have any questions at all related to the importance of normothermia in your stroke patients or anything in regards to targeted temperature management?
If you'd like to ask Laura a question, just a reminder to use *6 to come off mute. And we will just give a second. I know it takes a second to finagle your phone. So we've got quite a few of you on today, so I'm hoping somebody has a question for Ms. Laura. And Michelle, do we have any questions in the chat box that you could share with us if we do?
We have great comments saying this is great protocol and they would like a copy of the slide. We will send a copy of these slides to you.
And Allison, as well, when you send out the copy of the slides, I'm happy to, Delia and I can provide you guys with a couple of sample normothermia protocols also, along with contact information if people want to take a look at those as well.
Absolutely. I think that's definitely something we can share with everybody in the attachments. So I think that would be great. Okay. Just if we have any questions, feel free to type up and share those. I'm going to go ahead and jump to the next slide in the interest of time. And Laura, I just have one more slide, so if you want to just click over to the next one, that's fine too. This is our very last slide. And again, since we just want to make sure you have the contact information of the American Heart Director that's in your area, I've listed out each of the directors here in the left-hand side for all of their respective areas. I will note we've got 2 new directors. Actually, we have 4 new directors. Christy Esposito, Emily Jones have just signed on with us very recently in the last few weeks. So Christy will be covering North Texas, and Emily is going to be covering Denver and Northern Colorado and Wyoming. And then we have 2 new folks signing on as well that will be starting next week. That's why I put coming soon. Flannery O'Neill is going to be covering Southern Colorado, West Texas, and New Mexico. And Alicia Webster is going to be covering Oklahoma and East Texas. So if you fall in any of those areas, never fear. You do have a new director coming soon, and we will make sure you get connected with them once they start. And, of course, if you have any questions, feel free to reach out to myself, Allison, or Deb Motz is our Senior Director for Stroke. I think that covers just about anything. If we have any last-minute lingering questions, we're happy to answer those. If anyone has any thoughts they'd like to share with the group, best practices, anything like that, please feel free to come off mute using *6. Okay, well, that does that for us today. I see a comment over here. I like having deadline dates for quarterly data. This will help. Absolutely, and that's something we can surely provide you all with, is just some soft deadlines to make sure you have your data updated in there so we can send you a more robust report for your hospital. And unless anyone else has anything. Yes,
go ahead. We have one more question. We have a question from Courtney. What measure did you say we need to keep in mind that would probably be mandatory in 2020?
Oh, great question, Courtney. That is going to be the intensive statin measure that's currently actually a part of the quality measure set that's part of your plus measures. It's one that we've historically struggled with, but I will mention that the current format of that measure will change. Right now, as it stands, there's not a lot of exclusion criteria around that measure. That will be updated. Once the new guidelines come out and we have more reasons for not providing a statin to certain patient populations, I think that will make that measure a lot easier to meet. I think some of the biggest problems we have with it right now are that there's just not clear criteria for some of our more elderly populations or some patients that have had history with difficult use of statins. Perhaps they have like myalgias or something else that's caused them to not really tolerate statins very well. So there will be some exclusion criteria built into the measure once we get it updated. So great questions. Keep them coming. If you need to reach out via email, that is fine as well. And with that, I think we may be able to give you guys about 15 minutes back in your day. So again, thank you very much for coming on today with us, and we look forward to touching base with you all next quarter. Thanks, everybody.